Ahoy, and welcome in to another mind-expanding episode of Not Allowed to Die, your podcast about mental health, where I, Dan Megler, social worker and life enthusiast, answer your questions about mental health and pull back the curtain on how mental health treatment works and sometimes doesn't work. Alongside me, as always, is Mariska, the three-toothed Patterdale Terrier, and you may hear her, she was wheezing a little bit today. I think her allergies were acting up, but you do not hear her licking her paws. And we all know what that means. When Mariska's licking her paws, it means we have not been doing a good job of rating, reviewing, and sharing the podcast. And so it means you have been on your game. And the other thing Mariska always wants to remind me is to draw attention to Pause for Patrick. Remember, this podcast is brought to you in part to make sure everyone is aware that if you know a young person with mental health issues who could benefit from an emotional support animal, they should go to pauseforpatrick.org, where they can find the help that they might need to acquire an animal, get training, or an ESA letter. Now, tonight, both Mariska and I are incredibly excited because we have our most distinguished guest that we've ever had on the podcast. Dr. Chris Anandappa graduated from University of Illinois College of Medicine in 2008 and completed his psychiatric residency at the University of Michigan in 2012 and a forensic psychiatry fellowship at Michigan Center for Forensic Psychiatry in 2013. He also earned a certificate in sex therapy from the University of Michigan School of Social Work in 2013. He then completed the Student Mental Health Fellowship at the University of Chicago in 2014 before joining Loyola's Campus Wellness Center from 2013 to 2017. In January of 2018, he started working at the partial hospitalization and intensive outpatient level of care at Compass Health Center, Chicago. In January of 2022, he moved on to the PHP IOP at SunCloud Health in Northbrook, Illinois, where he also works in the residential facilities and is clinical director of the interventional psychiatry program. Dr. Anandappa is board certified in adult and forensic psychiatry from the ABPN. He also is board certified in adolescent psychiatry from the ABAP and is a fellow of the American Psychiatric Association. And as impressive as all of those things are, they are only a fraction of all of the different things that this man knows about. So this might only be one of many. I might be harassing him to talk about many topics over the time because in mental health, he's pretty much done it all. But tonight, we're really excited to hear some of his stories because he is working on some of the cutting edge of a couple of different areas that I've talked about in this podcast, wanting to learn about TMS and ketamine. So, Dr. Anandappa, thank you so much for joining us tonight. And can you tell us a little bit about your journey and how you got into this field?
Oh, thank you so much, Danielle. I appreciate it. And thank you for having me on your podcast. This is the first podcast I've ever been on, so I'm very excited. Well, I will say that my own journey to interventional psychiatry, as you were saying, including transcranial magnetic stimulation and a certain application of the chemical ketamine, really came as a result of my involvement in what's known as partial hospitalization intensive outpatient care. For those of you out there who aren't familiar with this, think of it as a level of more intense mental health treatment for individuals who need something more than seeing their therapist once a week or their psychiatrist every several weeks or every several months. But at the same time, don't need the acute and very intense level of care, such as being on an inpatient hospital unit. Along with intensive outpatient and partial hospitalization, as the name suggests, they're not quite as strong as the hospital or regular outpatient care. I've also been working in what's known as residential treatment. Residential treatment is a form of care where a person is inside a treatment facility. What's different sometimes than a hospital is that residential treatment is 100% voluntary. So you can't be court ordered for residential treatment, at least for most kinds here in the state of Illinois. But even though it's a voluntary level of treatment, it is something where you're sort of living in a therapeutic community. And for some people with certain diagnoses, individuals who have difficulty functioning on their own, or who lack the family and other personal resources for wellness. Other patients, I would say, probably struggle with illnesses that can affect their safety, such as really severe substance use disorders or eating disorders. And so for a lot of these people, that other step of residential care, I think of it as almost parallel to being on an inpatient hospital unit, but still different in some ways. those folks may need that. But as I was saying before, partial hospitalization, intensive outpatient, I started doing that in 2018 when a friend of mine from residency had told me about his experiences working at a partial hospitalization intensive outpatient in Chicago. And I was looking for a transition from, about 4.5 years or so of working on college campuses. And so that's how I got into that.
Well, I always think of it as inpatient settings are where you go to just get stabilized. People don't really get better, they just get safe enough to leave. And it's in these partial hospitalization programs where when we need a new way of viewing the world and new skills, and we need to really ingest them into our lives quickly with help with practice. Because as an outpatient therapist, I can help a person to learn new things. But in a partial hospitalization program or an IOP, you're working with people to say, how am I applying this? And we're getting those new kinds of skills. Is that kind of how you view it?
Oh, totally. The intensity, most people to participate at that level of care need to hit a timeout and take a leave from full-time work or full-time school and really dedicate themselves. A lot of partial hospitalizations are about 5 hours a day, Monday through Friday. I think the intensive outpatient level is defined at about 3 to 4 hours a day. Again, most Mondays through Fridays. And that level of care, insurances will often cover from anywhere from 4 weeks to 8 weeks, give or take the level of intensity. And you're exactly right. I have seen myself in, the 6 years, almost 6 years I've been doing this, patients starting from a very bad or negative place. And many, many people, by the time they're wrapping up, are feeling so much better. In particular, I notice a higher and a much a greater improvement in functionality after the weeks of commitment to PHP and or IOP. And so, it's, I think, a very dynamic level of care. And I think given a lot of the mental health things that we've seen really come to a head over the last several years. You probably have seen it as well during the years of COVID, during and after, how it really exacerbated mental health crises for so many populations, for so many age groups, and in so many different ways. And to some extent, I will add that it revolutionized PHP and IOP because, like a lot of other mental health and medical care, we had to go virtual. Instead of groups of people coming together in the collective space, we had to, in some cases, overnight, develop virtual solutions and get those running, as we did at the last company I worked for. And I think for many people, although it might have lacked the kind of in-person care that so many therapists and mental health practitioners feel almost was anathema, I find it surprising to look back on it and say, I think we did pretty good work. And I think our patients worked just as hard. And to build a sense of community, I think that too is a very important element of partial hospitalization intensive outpatient. You and I have probably talked to patients in an outpatient setting who say that, well, group therapy, I'm not really into that. I'd much rather talk one-on-one, and it's something that I don't think will be as helpful. But I will tell you that in the 6 years, I've seen patients spend a lot of their time in intensive outpatient and partial hospitalization in the actual therapeutic groups, as well as doing individual one-on-one therapy with therapists, psychiatrists, and sometimes other specialized mental health providers. I would say the vast majority of them really enjoy, learn, and develop skills from that collective experience in those group rooms with 5 to 18 or 20 people sometimes, that, well, I would say provides a level of learning that is a different experience than just one-on-one therapy.
For sure. I mean, when people hear feedback from peers, they take it in a different way than when they hear it from clinicians. And in addition, I think what people don't realize is how much it benefits the clinicians to watch the interactions for those individuals with other people. Because when a person comes to my office, they can create any universe they want in there, and I don't have anything to judge it against. But when I can see them interacting with other people, and I'm sure as a, especially when dealing with medication for people, it has to be almost the most ideal environment to see, oh, now I can see what the change that this medication is having, not just what the client is reporting to me, but also like the feedback that you're getting from other practitioners who are interacting with that person, watching them interact with other people. Because so often when people go to their psychiatrist's office on an outpatient basis, if they're starting a new medication, okay, we'll try this, see you in a month, and we'll see how it's going. Whereas in the partial hospitalization program, you're getting daily feedback on how that might be going. Do you find that it's helpful in that way?
Oh, extremely helpful. I think most of us will see our patients anywhere from at least once or twice a week. And in particular, you could say one of the interesting wrinkles is that with normal outpatient care, say you see a patient as a psychiatrist following up every 2 weeks to 4 weeks to 6 weeks or what have you, we are seeing the patients also with the benefit of many hours a day, 30 hours a week perhaps or more, of intensive psychotherapy. So even though it could be hard to say, well, is it the medications that made everything better, or is it the therapy, or a little bit of both? I would say that it's that level of intense experience that I think is so helpful for patients, and in particular to those patients who I see, as you can imagine, are still very skittish or worried about coming onto medication. I then adopt the attitude of like, hey, your psychiatric care and meeting with me and taking medications is only just a fragment of what your entire experience here is. And quite frankly, I would say that, yeah, for meeting with me 30 minutes to an hour after 30 hours a week is just this small piece in which your psychotherapeutic experience individually with other people doing activities, whether it's art therapy, yoga, going on therapeutic walks or other activities, really that multifaceted therapeutic experience. I think it helps build confidence in that, as I said, the treatment here is not just quote unquote throwing medications at the problem, but just one piece of so many different facets of an overall treatment plan.
Now, the vast majority of PHPs and IOPs, though, are, they might be dialectic behavioral therapy based, they might be cognitive behavioral therapy based, but at SunCloud, you guys are doing some additional things that are kind of more at the cutting edge of mental health treatment in transcranial magnetic stimulation and in using esketamine and whatnot. So could you talk a little bit about how, how do you decide, or how do you work with clients and families and the practitioners to determine who might be a candidate for, and you can start with either one, or TMS or the esketamine, but I'd love to hear, I want to learn as much as I can about both.
Oh, for sure. So as you can imagine, we have certain diagnoses, and probably the main diagnosis that people are familiar with is what we call major depressive disorder. And elements of that, again, depending on DSM-5, that's the Diagnostic and Statistical Manual, number 5, the Bible, if you will, that is produced by the American Psychiatric Association, but I think by which most mental health and medical clinicians use for diagnostic purposes, then with depression, you are looking at populations that are somewhat new to that diagnosis, and therefore might try out medications if their symptoms move in the moderate to severe category. But then you have a subset of chronically depressed individuals, what we might call TRD, for treatment-resistant depression. Now, there's no formal diagnosis of that in the DSM. Sometimes we would refer to that as a persistent depressive disorder. It used to be known as dysthymia. But I will say that it's these individuals who you might say interventional psychiatry has been created to address those diagnoses first. You would say that the newest technologies, both the neurostimulation technology of transcranial magnetic stimulation, but also something like esketamine, the ketamine-based treatment, really were first approved because I guess you'd say those diagnoses might be some of the most important ones. As you know, the most common mental health diagnosis is still depression. I think that still is anywhere between 7 to 11% of the population sometimes. And so it's no surprise that elements of both the FDA and the research communities, including the pharmaceutical industry and other mental health innovators, have looked at TMS and ketamine to treat depression first and foremost. And so going back to what you were asking before regarding intensive outpatient and partial hospitalization, I was working after about 3 years of doing this level of care and thinking about how an interventional option would really make sense to people with treatment-resistant depression who are in PHP and IOP. Some of the technologies that I'll be talking about really require a more intensive level of care. Something like transcranial magnetic stimulation. A patient will get a treatment every day, Monday through Friday, anywhere from 20 minutes to 40 minutes. And then, of course, with esketamine, the Spravato product that we use, that's anywhere from twice a week to once every other week. But because of the strength of that medication and how it affects a person, oftentimes after the administration of the medicine, their activities are somewhat limited. Most notably, you can't drive the day after esketamine. So it goes without saying that to be able to have someone not go to work or not go to school 5 days a week, and then add these additional treatments to that day really had a lot of synergy. And at the first clinic I worked at back in, I'd say by 2020, 2021, I had sort of broached the idea of adding these services. I think they were kind of focused on a few other things. Again, this was still in the middle of COVID or whatnot. But when I changed employers, I would say roughly within 6 months, 7 months of joining the PHP IOP I work at now, the leadership had thought, hey, this is a really great idea for our TRD patients. And we started putting things together almost exactly a year from now, actually, late October of 2022. So you're catching us at our 1-year anniversary, if you will, for our interventional psychiatry program.
That's awesome. And well, so can you take us through a little bit of the mechanics of either one of them, of how are they, what's the theory of how they are working in the brain and what they're doing to kind of interrupt that, that long-term depression that seems to be so hard to break through with?
For sure. So let me start with transcranial magnetic stimulation, or TMS. Now, I think a lot of people out there, especially if you've seen films like One Flew Over the Cuckoo's Nest, and then depicted in other films in different ways, other media, what people refer to as what we call electroconvulsive therapy. Other people refer to it as shock therapy. And you could say that the notion, or the, dare I say, almost the stigma of electroconvulsive therapy is something that really, in my career and probably for the last 30 or 40 years, has often been misunderstood by the mental health going public. I will say this, having trained in ECT, we had a special certification program in my residency at the University of Michigan, and trained with really some of the best experts in utilizing that tool for a number of diagnoses and administering it in a very humane fashion. People are anesthetized, their muscles are paralyzed the same way your muscles are paralyzed when you go into surgery. And it's done in a fully medical environment with anesthetists. There's always at least 3 or more doctors in the room there. And I will say this, for difficult cases of depression, as well as illnesses such as catatonia, or even in some cases of bipolar disorder, and I've seen it used for people with behavioral disorders that aren't as responsive to medications. Electroconvulsive therapy can be a very therapeutic mental health tool. That having been said, it is a very intense neuro electrical activity that if we didn't say paralyze the muscles of a patient, sending that kind of electrical signal in the brain can be very intense. And as much it is equivalent to like when you hit the reset button on your computer and you're basically rebooting it,
Mm-hmm.
By causing a widespread depolarization of neurons across the entire frontal lobe. That's where your limbic system is, where most of what we do in mental health is affected. It can have side effects such as short-term memory loss. It can cause a little bit of muscle discomfort as muscles do tense up. You wear a mouth guard, and so if your mouth guard wasn't set right, you can bite your lip or injure your teeth. And for a lot of people, it can be very invasive because people are put under anesthesia. We do it in a medical setting. We have to get intravenous access. And so you can imagine during a time like COVID or something, it was something that might have been even more complicated.
Mm-hmm.
However, if we look at electroconvulsive therapy as sort of painting with a broad brush and using an electrical signal in a very bold and dramatic fashion, transmitting a signal from one side of the brain to the other and the whole brain all at once, it begs the question, is there a better way to use that kind of signaling on a specific part of the brain that is less intense and less invasive? And as a result of that, we get to transcranial magnetic stimulation. As the name suggests, there is a stimulation to the brain, but unlike a direct current, we use a magnet to generate an electrical field. And in that generation of an electrical field, specifically addressing a part of the brain that we see is very affected in depression symptoms, we can slowly, after a number of days of treatment, demonstrate a significant improvement in depression symptoms by specifically targeting and in a less intensive and a more methodical process the parts of the brain we feel are involved in depression.
And now for people, like, is it also coupled with, I mean, obviously if they're in program, are they able to, like, is there afterward, is there an exhaustion level? Is there headaches or anything else like that people are experiencing? Or are they able to pretty much go along with their day after a treatment?
That's a very good question. And the fact of the matter is that many patients who start TMS, I would describe it because I myself put myself in the chair and had them deliver a certain amount of signal. The way I would describe it to most patients, it's almost like a feeling like there's a woodpecker tapping very quickly on a certain part of your brain, and it taps for a little bit and stops and then starts up again or what have you. In total, our device sends about 3,000 pulses to the left dorsolateral prefrontal cortex. With that having been said, we will start a patient with a little bit of an analgesic like Tylenol or ibuprofen. But I will tell you, Daniel, by say treatment number 15 or 20, so about halfway to 2/3 through, most people will say, you know what, they've adjusted to it quite well, and they don't even need to take an analgesic anymore because they don't really feel like it's causing any headache problems or things like that. So it from the headache perspective and from other kind of neuromuscular concerns, it's actually very, very well tolerated.
Yeah, I mean, we think all things, I mean, if we take a medication and it has side effects, everything has side effects. So it's balancing out what can I do and the level of effect. Now, how long after, so if a person does say, would it be for like, let's say would it be like 3 to 4 weeks of treatment? And if they did that, then about how long are they getting like a halo of like, are you finding like 6 months, or is it a permanent change? Like, what are you guys finding as far as how long the benefit of TMS might last for people?
For sure. So the exact amount of treatment one gets per day and the exact level of treatment, how many weeks, depends on the different type of TMS devices. Right now we have 2 kinds of devices, one called RTMS or repetitive TMS, and then we have another technology called deep or DTMS. And so depending on the technology, depending on the protocol used, some of those, most of them I would say last anywhere from 5 to 7 weeks. of a moderate amount of treatment per day. One of the things I can also talk about are some of these newer cutting edge treatments that are a lot more concentrated. So a 5-day treatment that has like anywhere between 8 to 10 treatments in one day, which was recently published in the American Journal of Psychiatry. They call that the SNT protocol. But going back to your original question there, is that I think that I would say that based on the evidence that I reviewed, at least half the patients will have a reduction in symptoms, and about 1/3 of patients might have a full remission in symptoms. Now, the amount of time a patient may stay in remission is very variable to the individual, but I think I would say in most of the cases, we're looking at anywhere from 6 months to a year. Now, I will admit that doesn't sound the best kind of outcome, but you got to remember, these are patients who've been on all sorts of oral medications and have suffered from really moderate to severe depression symptoms, sometimes for years or decades. And so the idea that a patient can get that kind of sustained relief, possibly for a 6-month period of time, sometimes longer, I think is a very powerful possibility.
Well, and sometimes when they're in that window of time when they're not feeling as distressed, they can make more progress in therapy, and they can come into issues that because I've found for my treatment-resistant clients, many of them have a trauma history that they've not been able to fully unpack because they're too low, they're too depressed, they're too low energy to get into it. But sometimes that might give them the runway and the energy to start to get healthier and work through some of those things. I guess that would be my hope. So, yeah, it's really, go ahead.
And I would add, Daniel, too, that, and again, not to spoil the surprise about where this is going, but I think what we're looking at, or at least what my take is in many ways there had been a view of mental health in which medications and other treatments are done by the psychiatrist or the psychiatric nurse practitioner, this kind of medically trained provider, and psychotherapy, whatever type of psychotherapeutic intervention, is usually managed by the psychotherapist. Well, I will say this, is that with interventional psychiatry and some of these other things coming down the line, and I know this is probably a whole other presentation, like psychedelic assisted psychotherapy, right? But the idea that the psychotherapy elements and these advanced treatments, whether it's neuromodulation like TMS, ketamine, like what we're doing with the Spravato product, but pretty soon, right, psilocybin, MDMA, these things that we've considered for many years to be illegal or illicit drugs or hallucinogens or bad things, but to realize that they work on parts of the brain and in different ways that independently they can provide a lot faster and a lot more intensive of a treatment. The idea of taking those advanced treatment modalities and adding psychotherapy to them, that, Daniel, I think is where the future mental health is headed now. And I think that future is upon us in some areas right now, but I think that's where it's going. And so you're exactly right. This idea that with a therapist working with a provider, a psychiatric provider, in incorporating psychotherapy with these advanced modalities. Again, sorry to spoil the surprise, everyone, but and I think that's very exciting because in some ways, right, you and I were talking about IOP and PHP, right? Under the same roof, in the same kind of setting, getting psychiatric management and psychotherapy, but imagine that integrated in such a dynamic fashion. And again, I think in particular to harness these interventional tools like TMS, like ketamine, but then add the psychotherapy on it, I think the evidence is going to show us people are going to get better faster, and it will be a more dynamic improvement in symptoms.
Now, when a person's going to do TMS, do they have to come off any other medications that they were taking going into that? Or are they able to stay on their medications while doing TMS?
That's a very good question. So I would say probably the of the couple things that we really concern ourselves about with TMS is, as you can imagine, what's happening in the brain when the signal is generated has to involve the conductivity of neurons in the brain. Certain medications, such as benzodiazepine sedatives, can actually decrease conductivity in the brain by their mechanism of action. So I would say we would tell patients to hold any kind of sedative like that, just so that we can have a good enough signal. Likewise, if a person is in the chair now, you're sort of wondering, well, if a woodpecker is tapping on your head, right, it'd be hard for you to fall asleep. But believe it or not, once we fall asleep, the brain actually changes the type of waveforms. If you looked on an electroencephalograph. So we tell our patients, you got to stay awake here because we want to treat you with all your brain waves kind of functioning in that same wakeful state. And then other than that, I think making sure you have a good night's sleep is important. Making sure there hasn't been any other changes to medication. As you can imagine, certain medications may be affecting the quality of signal in the brain. And so yeah, we always check in with our patients about that to see if there are any changes. But I would say those are the biggest things that we look for that might affect the quality of the TMS treatment.
Are there any clients for whom you would say it's not indicated, like it would be a bad idea to try TMS? I know, sometimes when I sometimes have some difficulty telling the difference between my treatment-resistant depression people and some people who might have a low affect schizophrenia where they just don't, like they don't emote anything. And so, but I mean, would it be contraindicated for people with schizophrenia or anything else like that? Or are they saying, okay, well, we're not necessarily seeing any negative outcomes, or, is there no concern about that? So just curious.
Sure. And I would say that the main contraindications are less psychiatric and more physiological. So as I was saying, the transcranial magnetic stimulation device uses a magnet to deliver an electrical signal. As you can imagine, if people have subcutaneous metal implants, and I'm not even talking things like earrings, because it's perfectly fine to have earrings, and I think we had a couple of people with some piercings of the lip or implanted retainers in their dentition. Again, because this is going on the upper left part of the skull here. But if you've had any kind of metal plates, any kind of metal in the skull, not as much in the neck if someone's had a cervical spine correction, but really I think those are the main contraindications for TMS, because of the magnetic signal will actually cause the metal to heat up. Again, it's conductive of electrical signaling, and so we wouldn't want that. And then I think the other population physiologically that we concern ourselves about are people perhaps with a seizure disorder. Now, I will say this: the rates of seizure in patients who receive TMS are extremely, extremely low. We're talking about not 1%. We're talking about tens of thousands of 1%, given the many tens and maybe even hundreds of thousands of TMS procedures out there. So I would say that unless somebody had a very, very brittle or poorly controlled seizure disorder, then that might affect whether they qualify for TMS. But other than that, I think patients with different diagnoses or diagnoses in addition to major depressive disorder, or possibly with other mental health conditions as well, and even medical conditions, I think are perfectly fine. I think to address your concern about fidelity of treatment, I think that's a little different, in the sense of when a patient makes a commitment to TMS, we like to see them through the entire range of treatment. So the TMS that we practice here at Sun Cloud in Northbrook, we were looking at about 36 treatments, roughly over 7.5 weeks. And so for a patient who might be, shall we say, a little flaky or have difficulties with commitment, or say, I'm going to go on vacation for 6 weeks or something, to that person, we might say, hey, maybe we should wait for a time where we can do all this treatment for you in one sitting without any kind of interruptions or delays or things like that.
Well, I want to now hear, if you wouldn't mind shifting, about just ketamine or esketamine. So can you tell us a little bit about that and what your experiences with it, like who that might be more indicated for? And because I've had just a couple of clients who've used it, and it has had a very profound impact very quickly in my just very limited experience of what I'm hearing. So can you tell us a little bit about, the history and how that's been starting to use esketamine?
For sure. So I will start out with the history of ketamine, the drug itself. Ketamine was first synthesized in the 1960s, indirectly as a result of research into schizophrenia and mechanisms in the brain which contribute to the dissociation and related mental status changes that often accompany that. It's not surprising to realize that one of the initial byproducts of this research was the substance known as phencyclidine, or PCP.
Okay.
And they were trying to consider, can this be used medically in some ways? Unfortunately, the intensity of side effects and the agitation that happened with phencyclidine made it really unsuitable for human use. But by looking at similar chemical compounds, we arrived at ketamine. And what was surprising is that for its initial use as an anesthetic, most of the time, we have anesthesias that make people sleepy, or they're gaseous anesthesias like halothane and things. You were able to use ketamine as an anesthetic that didn't contribute to respiratory depression. So as you can imagine, right, if you see movies in World War II, right, the medics were injecting people with syrettes of morphine, but by God, they had to keep control of it because the patient is in pain and suffering. And so if you went too much, it would cause respiratory depression. And unfortunately, you'd accidentally end that person's life. With ketamine, and this is something in the United States we saw deployed on the battlefields during Vietnam, we could use that for the acute pain relief, for the stabilization of wounded soldiers, to be transported to the surgical hospital without any concerns for respiratory depression. And at worst, they mentioned some of these sort of dissociative symptoms, but nowhere near the level of agitation before. Sometime in the late 90s and early 2000s, when ketamine was used for pain management, that is, not just for pre-surgical or post-surgical treatment, but in pain clinics for people with very severe and chronic pain, people who, as you can imagine, would otherwise be subject to the opioid disorder, opioid crisis. In treating those pain patients, what some individuals later shared with their mental health providers was that after a number of, and most of the time this was intravenous ketamine, most of the time when they've had those treatments after one or several, they would report that any coexisting depression symptoms had significantly decreased or had gone away altogether. And so, as you can imagine, by the time that anecdotal experience started hitting the research protocols, I would say in the early to middle 2000s, right? It really began a movement in psychiatry to consider non-traditional substances, so other than the medications, as ways of addressing depression. Fast forwarding a little bit, right? You would see, so by the years 2010, 2012, in a place like Chicago, you started to see different kinds of non-psychiatric providers allowing for intravenous ketamine to be administered, and in usually a protocol of maybe, say, an infusion of certain dosages, say between 4 and 6 infusions after about 2 or 3 weeks. A lot of people were finding their depression symptoms having significant relief. Now, that having been said, ketamine as a substance has been generic for a long time. And if a substance doesn't have a drug company that's willing to pay for tens of millions of dollars of comprehensive 4-step drug trials, then it's not going to get approved by the Food and Drug Administration. And because of that, without FDA approval, it's not going to get approved by insurances. Mm-hmm. So that was one of the wrinkles with intravenous ketamine, and also other types of ketamine, oral, intranasal ketamine.
Hmm.
And right now, a lot of that still isn't covered by insurance, and people have to pay anywhere from $300 to $600 an administration out of pocket when they're using standard ketamine therapy. Fast forward to about 20. What I'd say 20. I think it's 2018 or 2019. The pharmaceutical company Janssen, which is now part of Johnson and Johnson, had come up with a specific subtype of ketamine. Ketamine, for those chemists out there, is a combination of right-handed molecules and left-handed molecules. And when drug companies do this kind of research, they find out usually one hand is better than the other. So esketamine, or what we call the brand name of Spravato, was found to be the most effective type of ketamine. And what they found was stable in some set doses for significant release of depression symptoms. As you can imagine, Janssen paid tens of millions of dollars to get that approval for the FDA. And lo and behold, by about 2020 or so, it was one of the first ketamine products approved by the Food and Drug Administration, and therefore requiring a lot of American insurance companies to cover it.
That's so very new. And so again, that we're really right there. So now when you're seeing so who might, who's coming, when a client is or a patient's coming through, what might, is it again that same kind of person with that tradition, that depression that's just not abating? Is that who you might be recommending a ketamine treatment for?
For sure. You would say for esketamine or the Spravato product that we utilize, there are really two diagnoses that are very similar. One is, as I said before, what we call treatment refractory depression, very similar to what we would treat somebody with TMS for. But there's another diagnosis, something called major depression with suicidal ideation, that the folks who make Spravato have identified a slightly modified protocol as being very helpful. For example, for treatment-resistant depression, a patient may start off at the lower dose, approximately 56 milligrams intranasally, about twice a week for the first 4 weeks, then 56 to 84 milligrams once a week for about 4 weeks, and then ideally 84 milligrams perhaps once every other week. And really, this course of treatment continues until we see significant reduction in depression symptoms. The other protocol specifically involves something called major depression with suicidal ideation. In that case, we start off a patient at 84 milligrams twice a week for the first 4 weeks, and then start tapering down the medication in terms of frequency based on both the alleviation of suicidality and the depression symptoms as well. As it goes without saying, you can think of the MDSI protocol as something that ideally might be utilized in an inpatient hospital setting, because patients are often hospitalized when they're suicidal, and the idea that can we use something that will work faster than an oral medication, I think means a patient who is less symptomatic, but also maybe someone who doesn't have to take up a space on an inpatient bed, and that's important too.
Mm-hmm. So, and again, I'm hearing about, and you hear anecdotally these experiences, though, of some people feeling just a real change in the level of depressive feelings, sometimes from the first infusion. So in your experience, are you seeing, you don't want to overpromise, but are you seeing very quick impact in the people that you're working with from that, or?
For sure. So I would say, and just kind of ballparking from the numbers that we have so far, I would say at least 1/3 to 1/2, maybe I'd say to about 1/3 to 2/3 of our patients who have received this Spravato product have had a moderate or extensive decrease in their depression symptoms. I would say that about 1/3 of those patients have had only a nominal form of improvement. And I think that's very telling. I think in particular, as we were talking about before, when you have individuals with other diagnoses, trauma, personality disorders, or whatnot, you could say that could those diagnoses have been looking like depression? And in many ways, we've been trying to treat their quote unquote depression for so many months or years, but there's perhaps some other mechanism going on, some other wiring of the brain, as opposed to the chemistry of the brain, that really needs to be treated, and that might not be improved by any medication, really. So that's a very interesting, dare I say, almost a controversial situation sometimes, but it's definitely intriguing for sure.
So if a person though had like a diagnosis of something like BPD, this borderline personality disorder or whatnot, and would they be not then as like a good a candidate potentially for ketamine? Because again, very often they are also feeling very miserable and highly suicidal and whatnot. So
Exactly.
like if someone comes in and they've got, or it's kind of on, maybe they're under 18. So, and that's a good question for both of these. Are they FDA approved for usage? Like what is the youngest that a person could be treated with either TMS or ketamine?
So right now, in terms of FDA approval, both of these products are only approved by people over the age of 18.
Okay.
That having been said, there are plenty of research protocols that I've seen in different treatment facilities and child and adolescent psychiatry departments where they're doing work right now to get approval for both TMS as well as other ketamine products. Because ketamine itself, again, can be obtained for pennies on the dollar, and can certain child adolescent psychiatrists are using non-Spravato ketamine. We've seen it make improvements in a number, I would say mostly adolescent or late teenagers under the age of 18. I think once you go a little bit younger, that becomes a little bit more specialized. But I will add here that the reason why that people are doing this kind of off the book or in these specific research protocols is because they recognize that these young people are suffering, and like anything, drug companies are wary of doing protocols sometimes in children's brains because they're so concerned of the possible side effects and liability. But that having been said, it's only by doing that kind of research can we actually create protocols and learn if these younger brains, these less developed brains, can have a significant improvement when you use these interventional modalities.
So again, the same question of who would you say should really steer clear and not be like, who would not be a good candidate for using it?
I would say probably, as you can imagine, ketamine, as it moved from being a surgical surgical anesthesia to antidepressant treatment, got a lot of notoriety, especially when it was diverted from, say, veterinary use to street drug use, right? Special K, quote unquote, cat Valium and things like that. And even a certain amount of oral and intranasal ketamine during COVID had sort of gone from online treatment providers to the street, in which it's used as a party drug, as a club drug, and a drug of somewhat addiction and medical and physiological side effects. So I would say that someone with a dependency issue of different substances, especially with hallucinogens and especially of ketamine, might be a less ideal candidate for something like Spravato. I would say that individuals also who have problems with hypertension or uncontrolled hypertension, one of the side effects of Spravato is a transient increase in blood pressure, maybe about 30 millimeters of mercury or so. And so, yeah, if your blood pressure, say, was 170 over 95 or 100 or something, it's probably a good thing. Talk to your primary care doctor. You might need a little medicine to help get your blood pressure under control. And then once it's under control, we could probably consider something like Spravato. So those are probably two of the main groups that I would say might not be appropriate for Spravato.
And again, also this how long are people having to go that, like, is it like, say, 2 to 3 times a year they need to go in for infusions, or how for the people who you've seen, like, how long does it tend to last, or are they suggested to be how frequent would they be revisiting ketamine if they had going on for the infusions?
Sure. So right now, I would say that about right now about 1/3 of our patients will dose anywhere from 12 to 16 doses over, like I said, this kind of tapering off in the number of doses over a number of weeks. About 1/3 of our patients, will do that and have wrapped up and had such a significant improvement of symptoms. We use a tool called the Patient Health Questionnaire 9 or PHQ-9 to provide both an objective rating, so we can try and trend down the severity of depression symptoms, but we also ask subjectively, and we also kind of work with the patient and what their life is and what their demands are. Over the summer, we had a patient who had started maybe about 7-8 months before, but she was heading off to school in a different city. So we saw her numbers trend down and said, okay, well, we'll wrap you up by this time and then see how you do. So every patient, I would say, is a little different, but I would say that it's not uncommon at all that we would be treating someone anywhere from 2 to 3 months and then seeing how they do with improvements. And based on that, deciding whether we continue treatment or we do it once every other week, or say that, there's been significant improvement or non-improvement over such amount of time, then we decide maybe to stop the treatment.
Are there any other misconceptions about either TMS or esketamine that frustrate you, that you're hearing out in the media or whatnot, that you'd like to shine a little light on and say, okay, this is not people hooking car batteries up to their brains or doing things like, is there anything that you're hearing about that's just false and is pushing people away from getting help they might need?
For sure. Well, I think the first thing I would say is, and I guess, Daniel, this might refer to a little bit to that other piece I alluded to before, the use of psychedelics, because in some ways ketamine is not that far away from a psychedelic that uses unique mechanisms of action in the brain. It can cause things like dissociation and other kinds of very unusual somatosensory phenomenon because of its impact on really underused or differently used receptors in the brain and have a different kind of impact on them. And so, as I said before, this idea that esketamine as a control drug that's very carefully monitored when we give this in a medical environment, checking blood pressures, checking symptoms, checking and rating levels of, say, dissociation that happen from people who think of this as simple a street drug or a party drug, and that they're almost kind of quote unquote looking for the high there. And even though, a significant proportion, anywhere from 40 to 60% of people will have some period of dissociation, that period of side effect is why the patient is monitored that full 2-hour period after administration. So I think, that's what I would tell people right now, that this is very carefully done. It's followed very clear FDA guidelines. I will add that Spravato is part of what's called a risk evaluation and mitigation system, or REMS. So every patient with every dose of Spravato, a document gets completed with their vital signs and any kind of side effects and sent to the REMS system to make sure that any possibility of adversity is recorded. So I think that just really adds to the legitimacy of how we do it in this fashion. I think with TMS, it goes back to ECT, this idea that, we're trying to shock the brain and it's just placebo effect or some other kind of quackery, as there might have been seen at the turn of the century, But I will add that the evidence is very pervasive, that it can be very helpful. And as I was saying before, that when we can add different kind of psychotherapeutic treatments to things like TMS or ketamine treatments, they can be game changers. For example, I've been really talking about utilizing these things for depression. I don't know if you heard, Dan, that TMS can be used to treat obsessive compulsive disorder.
I have heard that, yeah. So that's also showing promise, huh?
Yeah, and in fact, the first treatments for obsessive compulsive disorder were later augmented by exposure therapy. And when you have exposure therapy, so a provocation of the OCD-related trigger, and then you treat the patient, the improvement, the quality of improvement and the length of improvement of OCD symptoms is outstanding. Is even far better than just TMS alone. So I would say that even where I work right now, I'm working with my management to create an opportunity to do provocation for patients with OCD so that we can use the same TMS machine to treat both treatment-resistant depression and hopefully very soon obsessive compulsive disorder.
Well, that's what I think people need to understand is for those of us who are clinicians and working with these clients who are, their OCD is such an exhausting disorder, or to this chronic depression that is not lifting for sometimes for years. We're looking for anything new. And that's why I'm so excited to have you on and so appreciative of what you're sharing with us and that the work that you're doing, because we need to be able to give people hope that the same thing that they were trying and not working over and over again, that's what leads people to want to give up. And knowing that there's innovations and they're coming down the pipeline, and this is a very exciting time in mental health. It fills me with a lot of excitement and joy to hear the things that you're saying.
Exactly. And as I said before, substances that we had considered absolutely unhealthy or less than helpful from a mental health setting, the psilocybin, right, magic mushrooms, if you will, or MDMA or ecstasy, or what I would like to think of compounds related to that could be absolute game changers for some of our most difficult diagnoses. That would include post-traumatic stress disorder. Mm-hmm. That would include other types of substance use disorders, such as dependence on opioids and dependence on stimulants, that we could use these, for lack of a better word, quasi-hallucinogenic compounds as a way to short circuit the addiction circuitry of certain patients, and or provide a very profound rewiring of the brain for individuals with trauma. Mm-hmm. As you've probably seen it, your share of trauma patients, many doctors train in VA hospitals. So I've seen my share of many male patients from the wars with different levels of post-traumatic stress disorder. I've treated many students, unfortunately, on college campuses who have been the victim of sexual assault and the pervasive trauma symptoms of that. And the idea here that, not to say that good, say, acceptance and commitment therapy is not going to work with these patients, or other types of evidence-based solutions, or even oral medications for that matter. But the idea here that the potential of these newer compounds, these different types of intervention, whether it's a neurochemical like ketamine or a neuromodulation tool like TMS, can really be game changers in the speed, in the efficacy, and dare I say, the utility of treating patients, getting a patient from decreased or lack of function to a moderate level of function and a decent quality of life, and that by combining these technologies with intensive psychotherapeutic practices, as I said, yeah, it's exciting. And this is what I think the future of mental health is, really.
Yeah. Well, where can people go? So let's say they want to learn more about getting either kind of treatment. A person listening to this, if they're living in Maryland, if they're living in Nevada, where would you recommend they start for trying to to learn more about kind of potentially getting a treatment of either sort?
For sure. So I would say that right now, I would recommend some of the better mental health and medical websites. That would include like Mayo Clinic, as well as I guess what's the one that comes with like well, I would say, yeah, probably starting with the Mayo Clinic, but also I would not rule out the National Institute of Mental Health or the National Association for Mental Illness, NAMI. Other groups include the Depression and Bipolar Support Alliance, and then also your local entities in certain states and regions that different departments of public health can provide that kind of information. For specific information, again, some of this might be a little too much for a consumer. You could look at the American Psychiatric website, psychiatry.org, or for clinicians who are interested, the website of the Clinical TMS Society has a lot of information about TMS, and the group called ASK3, the Association of Ketamine, it's ASKP3, the American Society for Ketamine Practitioners, Providers, and I forgot what the third P is, but yeah, so those would have more information for clinicians looking for, I guess you'd say, professional guidance about the future of both of these compounds.
And if people want to learn more about you and your work at SunCloud, where should they go to find out more about that?
For sure. You can go to suncloudhealth.com. SunCloud Health, as I said, is a partial hospitalization intensive outpatient provider with 3 campuses in the Chicagoland area, and including a new 4th campus in Gaithersburg, Maryland. Along with that, we offer residential treatment at 2 different facilities in Northbrook, Illinois, including one that's specialized in the treatment of co-occurring eating disorders and substance use.
Makes sense. Well, again, thank you so much for your time tonight. We really appreciate it. And so we may be reaching out for more questions and other topics in the future. As I say, you're a wealth of knowledge on many things.
Oh, thank you so much. I hope I wasn't too boring to folks out there, but this is such a very exciting topic. As I said before, I think this is the future of mental health. It's real cutting edge stuff. I tell people all the time, I may sound like I know what I'm doing, but I still feel like a babe in the woods with this here, since I'm a clinical provider, not a researcher. But it's very exciting and it's very hopeful. And as you were saying before, to encourage everybody out there listening to this to not give up, to keep on going, to reach out and get the help that they need, or the help they need for other people. So thank you very much, Daniel. I appreciate it.
Well, and for all of you listening, again, remember, if you have questions for Mariska and for me, email me at dmaiglerlcsw@gmail.com. And until we speak again, you can do whatever it takes to get you through this world. You are just not allowed to die.